Good morning. I'm Christine Thurston-Toppy. I'm the Director of State Affairs for NCQA. Welcome to our overview for states around HEDIS public comment for 2020. We're appreciative of your time today. We've organized this webinar with the intent of keying in on the themes that we believe to be most relevant from our HEDIS public comment and want to provide you with an opportunity to ask us questions after our content experts review the themes from public comment. If we can go ahead to the next slide, I'd like to provide some context for NCQA's work with states to date. And many of you, I'm sure, are intimately familiar with this, but I think level setting is always valuable. So for those of you who haven't seen this information recently, effective February of this year, we have roughly 30 states that are using NCQA accreditation as part of their Medicaid managed care program quality agenda, and 26 of those specifically require NCQA accreditation. So I think it's useful to understand where in the country the program is being used, and then also seeing the arrays of ways in which it's being used. 4 specific states have actually added the LTSS distinction requirements. Those are noted by the vertical white Vs. So Kansas, North Carolina, Virginia, and Pennsylvania each have requirements for the standards associated with managed long-term services and supports. So just wanted to point that out as states are evolving their Medicaid accountability framework. The NCQA programs, accreditation, and HEDIS are continuing to be a big part of that agenda. Next slide. And then just for level setting purposes, we're always engaging with states and trying to understand how the measures are being used. And practically speaking, we have an overview here of the ways in which we see it being used on the Medicaid side, as well as on the commercial side with departments of insurance and public employee benefit programs and the like. And as we engage this year in 2019 on the continued use of HEDIS in the plan level, we're also engaging with states to understand the other ways in which the measures are being used for derivative purposes, use in the provider group, use in the ACO, and so forth. So we're excited to engage with you as our state partners in those discussions, and look forward to talking with you further as the year unfolds. So with that, I will hand it over to my performance measurement colleagues, Emily Morden, Safine Byron, and Lauren Niles. Thank you.
Wonderful. Okay, so I'm going to be kicking us off our agenda here in terms of the public comment that we'll be covering. We have some measures that are proposed for retirement. We also have proposed changes to existing measures, a couple cross-cutting topics, and then some proposed new measures and a few notification of changes. So we'll go through these in order. And if we go to the next slide, I'll kick us off by covering the measures that we have proposed for retirement. Next slide. Okay, so the first 2 measures you see here, we're proposing these 2 utilization measures for retirement, ambulatory care and inpatient utilization. We're recommending retirement because these measures are largely redundant with other HEDIS measures, including 2 risk-adjusted measures that we have, our emergency department utilization measure and our acute hospital utilization measure. In addition, we have 2 access measures, including our adults access to preventive ambulatory health services measure and our children and adolescents access to primary care practitioners measure, which look at access to outpatient ambulatory care. So these other 4 existing HEDIS measures encompass most of the components that are currently in the ambulatory care and inpatient utilization measure, and so that's why we're proposing the retirement for those 2 measures. Next, just briefly, the osteoporosis testing in older women measure. This is a measure for Medicare only, and we're proposing retirement due to validity concerns of trying to capture osteoporosis screening through a survey question, which is how this measure is currently collected. Next, we have our disease-modifying anti-rheumatic drug therapy for rheumatoid arthritis measure, which looks at the percentage of members 18 and older diagnosed with rheumatoid arthritis and dispensed a disease-modifying anti-rheumatic drug therapy. And we're proposing retirement for this measure mainly due to the issue that some members we know have rheumatoid arthritis but have that condition in remission. And studies indicate that 10 to 15% of patients with rheumatoid arthritis can achieve sustained DMARD-free remission. So the measure's face validity suffers if we're not able to exclude this population, and our experts could not recommend a method for how we would identify those with remission for the purposes of exclusion. We also think that the measure performance may have reached a ceiling effect given the various reasons DMARDs may not be prescribed. So in addition to those who have DMARD-free remission, we know that DMARDs may not be prescribed for those patients who are more frail or who have experienced serious side effects from the medications. So those are the reasons we're proposing retirement. Next, we have our use of multiple concurrent antipsychotics in children and adolescents. This measure assesses multiple concurrent antipsychotic use among children age 1 to 17. And since this overuse appropriateness measure was first introduced in HEDIS 2015, we've actually seen performance rates improve, which is great. And our most recent HEDIS results indicate that there is now little room for improvement. So performance rates are low, which indicates better performance, and there's little variation in performance. So we're proposing retirement. And then lastly, we're proposing to remove 4 items from the CAPS 5.0 survey, the 4 items you see here. And we received broad public support last year for our proposal to shorten the CAPS survey. And we also did an analysis to look at the reliability of these different indicators in the CAPS survey, and these were the 4 items that did not achieve acceptable reliability based on that assessment, so we're proposing them for removal from the survey. And with that, I will turn it over to Sistine on the next slide to take us through proposed changes.
Great, thank you, Emily. Hopefully everyone can hear me. So we're going to talk now about proposed changes to the existing measures in HEDIS. Next slide. Great, and so you'll see here that we have several changes, and I'm actually going to focus on most of the commercial Medicaid measures since those will be the most relevant, and that way we won't hopefully run out of time. The prenatal postpartum care measure is being reevaluated in response to new guidelines from the American College of Obstetricians and Gynecologists. So they have released an updated recommended schedule in terms of the postpartum visit. And so we are proposing to align our postpartum visit timing with the ACOG guidelines and replace what we have in there with an earlier visit, a later visit, and then a rate that looks at both early and later visits. So the early visit would be one that occurs within 3 weeks after delivery. And the second one would be a visit that occurs between 4 and 12 weeks after delivery. And then the third would be looking to see who had both of those. So I'm aware that this is in the core set, so I wanted to highlight that. We were not making any recommended changes to the prenatal rate of that measure. So the second measure is the cervical cancer screening measure, and this again is being recommended for changes based on an update from the U.S. Preventive Services Task Force that has a new guideline recommending primary HPV testing as another method for cervical cancer screening. So we are proposing to add primary HPV testing as another method. We would also leave the cytology and co-testing methods in the measures. All right, and so the next set are the 3 HEDIS antibiotic measures. So these are measures looking at bronchitis, upper respiratory infection, and pharyngitis. And those three measures, right now, the bronchitis measure applies to adults, and then the latter two apply to children and adolescents. We are proposing to expand the measures so that each one encompasses all the different age ranges. And so we would be expanding the bronchitis measure to children and to older adults, and then we would be expanding the two-child measures to adults and older adults. So that's really the biggest change there. And we would then consequently be adding the Medicare product line. Another change that's being proposed is to switch this measure from being a member-based measure to an episode-based measure. So right now, the measure focuses on members and looks to see the first antibiotic prescribing event. But if we were to switch it, we would look at every episode that occurs. So a member could appear in the measure multiple times if they've had multiple episodes. All right, and then the safe and judicious use of antipsychotics in children measures. There are two here that we are recommending some changes to. This would be the metabolic screening measure and also the use of first-line psychosocial care measure. So here we are proposing to combine the bottom two age strata, the 1 to 5-year-olds and the 6 to 11-year-olds. Right now, the 1 to 5-year-old age stratum tends to be very small, and because we end up not having enough denominators in that age group who are meeting the other requirements for antipsychotic use, health plans have not been able to report that. So we think that by combining those, we'll get enough denominator to be able to report those rates in the youngest children. We are also proposing for the metabolic monitoring measure to split out the blood glucose and the cholesterol testing rate. Right now, that's one rate that just says, did you get both of these? And so we'd like to see who got blood glucose testing and then who got the cholesterol testing, so that we would be able to focus our quality improvement efforts and highlight the differences in who might be getting one versus the other, and then also looking to see who got both. All right, so I'm going to skip the next one since that's a Medicare-only measure, but we did include it here in case you're interested. The next slide. And the next two measures are also Medicare-only measures. So I'm going to hand it over to Lauren Niles, who's going to explain the reevaluation of the antipsychotic medication for individuals with schizophrenia measure.
Great, thanks. This is Lauren Niles. So the first measure that you see here that's not Medicare is the adherence to antipsychotic medications for individuals with schizophrenia. This is a measure that's been in HEDIS for a while, just assessing the Medicaid product line. It's also a measure that's in the behavioral health course set, so you're probably pretty familiar with it. The only change, it's not substantive in nature, the only change is that we're going to be expanding this to assess adherence among those enrolled in Medicare and also commercial product lines. And then the final proposed revision that you see here is for the use of opioids at high dosage measure. This measure you're probably pretty familiar with because it's very new. We first put it in HEDIS in 2018, and it was approved for public reporting for the first time in HEDIS 2019. This measure is based on a measure that was originally developed by Pharmacy Quality Alliance, PQA, and we're in constant communication with them, and this year they're actually making a number of revisions to this measure. So we wanted to take a look at that, look at their revisions, and see if it made sense to include those in our measure. There are two proposed revisions that we're bringing forward for public comment, and this measure would apply to all three product lines, including Medicaid. The first is, right now in the measure, we are setting a high dosage threshold at 120 MME and above. The change would be to reduce that MME threshold down to greater than or equal to 90 MME. This is not only consistent with what PQA is doing in their measure, but this is also consistent with the CDC 2016 opioid prescribing guidelines. And then the second revision to this measure is the modification of our index prescription start date. In the measure, we're looking for an average daily dosage that would be greater than 120 right now, MME. But to anchor that treatment period over which we're looking for an average daily dosage, we use this index prescription start date. And right now, there's a discrepancy between how PQA identifies that treatment period and how we identify that treatment period. So this proposed revision is to bring us in line with what PQA uses in their measure and kind of harmonize these measure definitions or these pieces of the measures across the measurement space. Next slide, please. Great, so I'm going to take us through a couple cross-cutting topics, or I'll take us through the first of the two. Next slide. So the first is something we've been working on for a while here at NCQA. It's our telehealth inclusion in our HEDIS measures. So beginning back in 2016, we started taking a hard look at all of our measures in HEDIS and looking at evidence that existed to see if it was appropriate to use telehealth services in the place of in-person visits in any of our HEDIS measures, either in the denominator, the numerator, or the exclusions. What we found is that there really was a great opportunity here to include telehealth in our measures, and to date we've included telehealth in about a third of our HEDIS measures, which is pretty amazing. And here what you see is the last 4 measures that we are recommending telehealth be included in. This is something that we put forward to public comment. Another important thing that kind of came from all of this work and looking at telehealth and learning more about how it's being used is it's really kind of changed how we are developing measures now. So now when we're developing or reevaluating a measure here at NCQA, one of the things we are taking a look at is the evidence that exists around the use of telehealth and telemedicine for that particular condition or diagnosis or procedure. So now I'll pass it over to Emily Morden. She's going to talk about our digital measure strategy.
Great. So I just wanted to cover what we've posted for public comment for our digital measure strategy. NCQA actually has efforts underway to support greater use of standardized electronic clinical data for HEDIS reporting. So this would be the use of data coming from registries, electronic health records, case management systems, in addition to claims. And this effort also includes adding digital formats to our measure specifications, following the quality data model and using clinical quality language, or CQL. And this really helps to increase the standardization in how our measure specifications are expressed. We also think it's going to reduce programming burden and really better aligns our specifications with electronic clinical quality measures that may be used at the provider level for reporting. So for public comment, we've posted information about NCQA's approach to both add digital formats to our specifications and also to increase the reporting of measures using the electronic clinical data systems method. And we're actually proposing for 3 existing HEDIS measures to be voluntarily reported following the Electronic Clinical Data Systems, or ECDS, reporting standard for HEDIS 2020. And these include the 3 measures you see here: breast cancer screening, colorectal cancer screening, and follow-up care for children prescribed ADHD medication. So as we introduce ECDS reporting for these first 3 measures, NCQA will actually continue to collect results for HEDIS 2020 following the traditional administrative and hybrid methods as well. So the results from those traditional reporting methods will continue to be used for benchmarks and for programs while we evaluate the ECDS reporting that's again voluntarily reported for this first year. So we're really excited about this effort and transitioning HEDIS measures to this new reporting method to better allow additional data sources to be used in a standardized way for reporting of measures. And with that, I will turn it over to begin discussion about the proposed new measures.
Great. So I'll start us off here. We have, this is Laura Niles again. We have 4 measures that we're proposing for inclusion, potential inclusion in HEDIS 2020. You can see the 4 measures here. We'll kind of talk through them in turn. But one thing I want to point out is that the first 2 measures that I'll bring us through are admin-only measures. And then the two additional measures here you see that are related to the perinatal population, those are going to be relying on electronic clinical data systems. Next slide, please. So, as I said, I'll take you through the first two measures. They both have to do with substance use disorder in that population. So this first one here is follow-up after high-intensity care for substance use disorders. Really, this measure is meant to assess timely follow-up care and continuity of care following high-intensity visits for those that have a principal diagnosis of substance use disorder. Specifically, this measure assesses the percentage of inpatient hospitalizations, residential treatment stays, and detoxification events for a principal diagnosis of substance use disorder that result in follow-up, and this is among members aged 13 and older. And I do just want to mention that when we say substance use disorder, we actually mean opioid use disorder, alcohol use disorder, and also other drug abuse and dependence. I also want to point out the numerator for this measure. It's very consistent with the numerators that we have in our other follow-up measures in our HEDIS portfolio right now. So there'll be two indicators that are reported, one that's looking for follow-up within 7 days after the visit or discharge, and the other looking for follow-up within 30 days after the visit or discharge. And we are hoping to have this measure assess care across all three product lines, so Medicaid, but also commercial and Medicare as well. We are bringing this to our public comment period, and there are a couple questions that we're going to be asking during, or we're hoping for feedback from the public on during the public comment period, in addition to just the measure in general. One of those questions is we'd love to learn more about how billing for residential treatment that is not overnight is being billed and reimbursed for right now. We have codes right now in the measure for overnight residential treatment, especially in inpatient settings, but we're hoping to find out more about kind of those per diem situations. And then the other thing we're hoping to learn more about is services that are rendered and pharmacotherapy that is dispensed in opioid treatment programs and how that is being billed and reimbursed. It seems that, especially among states, there are different ways that this is happening between the state and these opioid treatment program facilities. And so that's something we're spending a lot of time thinking through and trying to understand more on this end, and we're hoping for some help in that. Slide, please. Great, and the second measure related to substance use disorder is our pharmacotherapy for opioid use disorder measure. This is a measure that assesses the percentage of new episodes of opioid use disorder pharmacotherapy that result in 180 or more covered treatment days, and this is among members that are age 16 and older. For public comment, we're soliciting feedback on a few things. Again, as I mentioned on the last measure, we're really interested in learning more about the billing and reimbursement of pharmacotherapy that is dispensed in opioid treatment programs. We're also looking for feedback from the public on the age range that we're including here, and also the negative look-back period that we're using to identify new episodes of pharmacotherapy. And then finally, the last thing we're hoping for some feedback on is knowing that this is a population with increased use of these high-intensity care settings. We're interested in knowing what folks think about hospitalizations that are occurring during this adherence period. Right now, we're thinking we may have to pause the adherence period when someone is admitted, and then begin it again when they're discharged, just because it's a little bit of a black box that goes on during that hospitalization. But we're certainly open to exploring other ideas there, and look forward to getting that feedback. Okay, and I'll turn it over for the perinatal measures.
Great, thank you, Lauren. All right, so as Lauren mentioned, these next two measures are being specified for the electronic clinical data systems reporting method, and we're looking at two measures to get at perinatal screening of depression and also follow-up. So the first is prenatal depression screening, and these measures align to recommendations from the U.S. Preventive Services Task Force, ACOG, American Academy of Pediatrics that all recommend screening during pregnancy or afterwards. So this first one is focused on the prenatal period. It's percentage of deliveries in which women were screened for depression, and if they are screened positive, received follow-up care, which could include a referral or something that says that they are following up on that positive screen. It's delivery-based, looking at whether members were screened using a standardized instrument. It would apply to commercial Medicaid plans. All right, and the next measure. So this one is focused on the postpartum period. So this looks at deliveries in which the woman was screened for depression post-delivery, and again, if screened positive, was there follow-up, some sort of follow-up, which could include a referral or a diagnostic test that says that a positive screen was addressed. And for this one, we are looking at a screening within 12 weeks or 84 days post-delivery. And this would also apply to commercial and Medicaid product lines. One thing we're particularly interested in hearing about is that timing of the 12 weeks post-delivery. We do understand that in some cases, Medicaid members who might have gotten coverage particularly and only because of pregnancy may lose that coverage 60 days post-delivery. And so, however, ACOG and others recommend this visit happen by 12 weeks after delivery. And so our thinking is that we wanted to make sure we were aligning with the clinical guidelines that were being given. So a clinician who is screening, at the 12-week mark is following guidelines. However, we do understand that there are issues potentially with the way the coverage is structured for Medicaid. And so we're particularly interested in hearing in public comment about that proposal for this measure. All right. And that ends the new measures that we are proposing for HEDIS. So the last thing we had is a notification of changes for HEDIS 2020. So these are not items for which we are seeking public comment, but they are items that we are just notifying plans about. The first is that we are removing the standardized healthcare associated infection ratio measure, which was not approved for public reporting and so was suspended last year. So at this point, we are going to remove that measure. The second is that we are removing the audit requirement from our board certification measure, which is a health plan specific measure. And we are going to retire the annual monitoring for patients on persistent medications measure. And we are going to be releasing the hard copy of HEDIS Volume 2 on July 15th, although the electronic copy will still come out on July 1st. All right, so that ends the items that we have that are currently out for public comment, and public comment goes until March 11th, so we definitely encourage everybody to go to the website and please submit your comments. However, it looks like we might have time for questions, and so I'll pass it back to Amy or Christine.
Great. Thank you, Safine and Emily and Lauren. We appreciate you doing the review today. Amy will be facilitating questions via the chat box. So if you have a question about any of the measures or would like to respond to some of the questions our team posed that are currently out for public comment, we would welcome any and all. We've scheduled ourselves for the full hour going until 1 p.m. Eastern Time.
We have one question coming in. Can you please explain the timing of these changes since we are already into the measurement year?
Yeah, this is Safine, so I can address that. This is the current timeline for HEDIS is that we tend to release these in July, which is July of the measurement year. What HEDIS has done previously is because the mid-June deadline for submitting HEDIS results happens in June, then the way it has typically worked is that health plans are busy doing their data collection in the first half of the year, and then they submit the results from the previous measurement year by June. And then after that, they turn to the new measures in July, which is when they receive the information. There are some advantages in that we are able to move quickly and release information on the measurement year pretty quickly after it happens. That said, NCQA has done some work to see if there was a way to release our specifications prior to the measurement year. We actually just completed a feasibility study last year to see if we could move the deadline earlier. And we had released last year for public comment a proposal to move the publication of the specifications to the July prior to the measurement year. So instead of them coming out and applying immediately, they would apply to the next year. And we are now in the process of working through how this might be implemented and whether whether July would be the date or if we might make some tweaks around that. But I will say that we are committed to releasing these specifications prior to the measurement year. And so that should be coming in the near future. So stay tuned for that.
We have another question in. For the osteoporosis management in women who had a fraction, we agree with the changes 1 and 4, however, think that change number 3 needs to have a separate measure to include long-term care. What is the family value set?
I think the frailty value set is what the question's about. So for the osteoporosis management measure, we have an exclusion to remove individuals with advanced illness and frailty and those living long-term in institutional settings. This is really to focus the measure on those who may better benefit from the screening and treatment that we measure or that we look for in this measure. So the change that we have for this for public comment is that we're just actually adjusting the timing of that exclusion so it better matches with the timing of the measure. But that is an existing exclusion, so it's been in the measure and will continue to remain in the measure.
I would ask our performance measurement colleagues, are there any comments that you've seen so far that have come in or you've heard from our other conversations with stakeholders since public comment's been open that you think would be interesting for this group to react to or might be of be of relevance?
Yeah, this is Safine. I would say not yet, although we tend to see the bulk of our comments come in towards the end of public comment, understanding that many people are preparing their comments, vetting the information that they're seeing, and probably like here, it's all soaking in. And so, but definitely we do appreciate hearing from everyone. NCQA reads every comment that we receive. So we do encourage you to send comments into the public comment system if you're able.
Okay. So I think with that, we appreciate your time today. If you do have follow-up questions, certainly comments, we encourage you to submit them through the public comment format. That allows our team to look at comments collectively and assess kind of consistent issues across stakeholders. It's truly the best and most productive format for us to hear from you. And we as your State Affairs team are always here as a support to you as well. So thank you to each of you for your time today. We always appreciate your engagement and look forward to continuing our conversations with you throughout the year. Thank you again.